Here I'm going to discuss different genes and viral infections that can lead to the development of cancer. And then after that, I will go over different tumor markers that are used for monitoring the progression or regression of specific cancers. Now, before I'm going through these mechanisms, what I would like to do is to go over some basic terminologies. And after discussing these terminologies, it would be easier to understand the processes that would lead to the development of cancer. So atrophy is the process through which both the cell size and number decreases. So decreased cell number is done via apoptosis. And apoptosis, I have discussed it in a separate video, so here I'm not going into too much details, but just to quickly summarize, there are two mechanisms through which the apoptosis can develop. One is the extrinsic pathway, where the Fas ligand binds to the receptor, or also tumor necrosis factor can bind to receptors and cause activation of caspases, which lead to the initiation of apoptosis, which is a programmed cell death. Alternatively, the cytotoxic T cells can release perforins, open up the cell membrane, and then release the granzymes, which would again lead to the activation of caspases that again will initiate apoptosis. There is the other mechanism called intrinsic pathway, where the overexpression of BAX or P53 gene or decreased expression of BCL2 gene will cause release of cytochrome C from the mitochondria, which will again activate the caspases. Now you can see that if we decrease the expression of BAX and P53 or increase the expression of BCL2, what happens is that there will be decreased apoptosis, as a consequence of which now there would be increased risk of cancer development. In any case, back to the table, decrease in cell number is being done by apoptosis, and then decrease in cell size can be done by ubiquitin proteasome enzymes, which will break down the cytoskeleton, or it can be done by autophagy, which means self to eat. And so autophagy is a self-destruction process. So again, atrophy is done via two different processes, decrease in cell size and decrease in cell number. The other term is hypertrophy, where there would be increase in cell size, for which it requires activation of genes, which will increase the protein synthesis as well as organelle production. And at the same time, there could be hyperplasia that is present with the hypertrophy. So one example of hypertrophy is, for instance, your skeletal muscles. After you work out, your muscle size increases. And so that's an example of hypertrophy. The next term is hyperplasia, where there would be increase in cell number. And so if there is pathologic hyperplasia, then there is an increased risk of cancer development. One example, for instance, is endometrial hyperplasia, which can lead to the uterine cancer. But then there is an exception, which is benign prostatic hyperplasia that would never progress into cancer. The next term is metaplasia, where there is a reversible change of one cell type into another. For instance, there could be a change of columnar cells into squamous cells or vice versa. And so metaplasia is again another condition that can progress into dysplasia and cancer. So far, hyperplasia and metaplasia had the potential to develop into dysplasia as well as cancer. Now, one exception for metaplasia again is the apocrine metaplasia, where there is transformation of breast epithelial cells into apocrine glands. And this condition also does not progress into cancer. But then the rest of the forms of metaplasia can progress into cancer. So there are a few examples of metaplasia which you need to be familiar with. One example is Barrett's esophagus, where the squamous cells in the lower esophagus, after exposure to the stomach acids, will transform into non-ciliated columnar cells. So squamous cells are not fit to handle the stomach acid, and so the cells will undergo a metaplasia in the form of columnar cells, which can better resist the stomach acid. And so this is a form of metaplasia that can lead to the development of esophageal adenocarcinoma. Another example of metaplasia is in smokers, where inside their lungs, the ciliated columnar cells of trachea and bronchi will transform into squamous cells. And then one other example is myositis ossificans, where skeletal muscles will be replaced by bone. And usually this condition, myositis ossificans, is from trauma and excess bleeding inside the muscles that will cause conversion of the muscle cells into bone cells. And again, conversion of one cell type into another is referred to as metaplasia. The next condition is dysplasia. So both metaplasia and hyperplasia can progress into dysplasia with the exception of apocrine metaplasia and benign prostatic hyperplasia. Now, the type of changes that you will see with dysplasia, which is just one step before developing cancer, is abnormal proliferation of cells as well as changes in the cell size, shape, and orientation. Other changes that you will see with dysplastic cells, for instance, include hyperchromatic changes where there would be increased pigmentation, increased number of mitotic figures, as well as nuclear enlargement, as a consequence of which you would see elevated nuclear to cytoplasmic ratio. Now, one example of dysplasia is, for instance, the cervical intraepithelial neoplasia, which is the term that is used to describe dysplasia in the cervical cells. And so there would be different grades, CIN1, CIN2, and CIN3, which describes the mild, moderate, and severe forms of dysplasia seen with the cervical cancer. But note that with dysplasia, there is still no invasion of the basement membrane. The next condition is CIS, which is a severe form of dysplasia where the entire thickness of the epithelium above the basement membrane has been changed into dysplastic cells, but then still the basement membrane has not been invaded with the CIS. And then neoplasia is the condition where there has been invasion of the underlying tissues. And neoplasia is being done by the collagenases as well as the hydrolases, which will break down the basement membrane and allow the cancer cells to spread to different tissues and metastasize to distant sites. So just to summarize the findings that I just discussed with you, normal epithelium can undergo atypical hyperplasia or metaplasia, which can progress into dysplasia, into carcinoma in situ, and then finally break the basement membrane and metastasize to different sites. So let me show you some visual examples so that you would be better familiarized with these terms. So here we have the normal cells, and so here is an example of atrophy where you can see that both the size and the number of cells has decreased. So it depends how we would like to define atrophy. If you're talking about cellular atrophy, then there is a decrease in cell size due to the loss of the cellular organelles. On the other hand, if you're talking about organ atrophy, then there could be a mix of decrease in both cell size as well as the cell number. Once they undergo hypertrophy, they would increase in cell size. Once they undergo hyperplasia, they would increase in cell number. With metaplasia, they would change from one cell type into another. So for example, the squamous cells of the lower esophagus, after repeated exposure to the stomach acid, transform into non-ciliated columnar cells, and this condition is referred to as Barrett's esophagus. Alternatively, the ciliated columnar cells inside the trachea or bronchi of smokers can convert into squamous cells, and this is another example of metaplasia. Dysplasia is a condition where there is increase in cell proliferation, and so the type of the cellular changes that you would see with dysplasia includes, for instance, change in cell size, shape, change in cell orientation, increase in pigmentation, increased number of mitotic figures, as well as nuclear enlargement, as a consequence of which there would be increased nuclear to cytoplasmic ratio. Now, I would also like you to know that dysplasia and metaplasia are still reversible. So for instance, if you resolve the gastroesophageal reflux where there won't be any more reflux, the Barrett esophagus is still reversible. Same goes with dysplasia. If there are dysplastic cells in the cervix, they could still revert back into the normal cells. And then once the dysplastic cells invade the basement membrane, this is referred to as neoplasia. So here I have an example of the cervical changes that can lead to the development of cancer. So first we have the normal epithelium. They would undergo mild dysplasia, which is referred to as CIN1, and only 1/3 of the thickness of the epithelium is affected. Moderate dysplasia, up to 2/3 of the thickness is affected, and then with severe dysplasia, the entire thickness of the epithelium is affected. And then the other term that is used to describe CIN3 or severe dysplasia is carcinoma in situ. And then once the basement membrane is broken, then cancer will invade the other tissues. So just notice that in all the conditions before cancer invasion, the basement membrane has been remained intact. And then before moving on to different mechanisms of carcinogenesis, there are a few other terms I would like you to be familiar with. Desmoplasia, which is an irreversible process, and in this condition there is excessive fibrous tissue formation, as a consequence of which it will give the neoplastic tissues a rock-like consistency. Anaplasia is also an irreversible process where the cells will lose the ability to differentiate. Now, there are two forms of malignant cancers for which you will have to be familiar with the term. One is sarcoma, where the malignant tumors have developed from mesenchymal cells, examples of which are tumors that develop from mesoderm. So if you recall from embryology, mesoderm gives rise to smooth muscles, skeletal muscles, cartilage, bone, vessels, fibrous tissue, as well as lipids. So here you can see that all these terminologies, all these forms of cancer have the sarcoma in the end, because they have all arise from mesenchymal tissues, which are derivatives of the mesoderm. So leiomyosarcoma is the cancer of the smooth muscles, rhabdomyosarcoma is the cancer of skeletal muscles, chondrosarcoma is cancer of the cartilage, osteosarcoma is cancer of the bone, liposarcoma is cancer of the lipids, angiosarcoma is cancer of the inner lining of the blood vessels, which are the endothelial cells, and then fibrosarcoma is a malignant tumor that is derived from fibrous connective tissue. Carcinoma, on the other hand, is referred to the malignant tumors that arise from epithelial cells, and the embryonic origin of these cells is either ectoderm or endoderm. Examples of which include, for instance, hepatocellular carcinoma, renal cell carcinoma, or squamous cell carcinoma of the lungs. Alright, now that we are done with all these terminologies, we can go over different mechanisms of carcinogenesis. So oncogenes are genes that will enhance the cellular proliferation. So if there is a mutation that will overexpress these oncogenes, then there would be increased risk of cancer. Tumor suppressor genes, as the name implies, decrease the chance of developing tumors by decreasing their proliferation. And so inactivation of these genes will again lead to development of cancer. And then finally, there are viruses that can cause cancer. So let's review those mechanisms, and then after that we can review different tumor markers that are used for monitoring progression of different cancers. So here I have a table for different oncogenes, and I agree, if you want to memorize those, it's not really fun. But what I'm going to do is that I will provide you here with some memory aids that hopefully will make the understanding of this table much easier and even to some extent fun to review. So NMEC as well as LMEC, these are the nuclear regulatory proteins that can lead to the development of neuroblastoma as well as small cell carcinoma of the lungs. So it's really easy to associate these two oncogenes with neuroblastoma and lungs, and it's that NMEC is associated with neuroblastoma while LMEC is associated with the small cell carcinoma of the lungs. The next oncogene is the c-KIT, which is a cytokine receptor that can lead to the gastrointestinal stromal tumor. And the way you can memorize it is KIT, cat. So once you eat Kit Kat, where does it go? It will go directly into your gastrointestinal tract. So now you can remember that c-KIT is associated with gastrointestinal stromal tumor. The next oncogene is ABL, which is a tyrosine kinase that can lead to the development of chronic myelogenous leukemia as well as acute myelogenous leukemia. And then if AML undergoes blast crisis, then it would convert into ALL. So let me review this ABL gene with you in a little more detail, because this is a very high yield topic. So the memory aid that I have for you for this BCR-ABL gene, which can lead to the CML, is I'm a tiny boy that likes Philadelphia caramel ice cream. So Philadelphia chromosome refers to that BCR-ABL translocation of chromosome 9 to 22. So here you can see that the ABL gene is on chromosome 9 and BCR is on chromosome 22. Once ABL breaks off from chromosome 9 and is transferred to chromosome 22, this is referred to as the Philadelphia chromosomes. And this chromosome can lead to the development of CML as well as AML. So caramel stands for CML, which stands for chronic myelogenous leukemia. And then for the treatment of these patients, we provide them with the imatinib. So I'm a tiny boy, I'm a tiny boy. Imatinib is used for the treatment of CML caused by the Philadelphia chromosome. Next, we have oncogenes that can lead to the development of the B-cell non-Hodgkin lymphoma, including the Burkitt's lymphoma, Mantle's lymphoma, as well as the follicular cell lymphoma. So the memory aid that I have for you here is called Birdman flies. So let me go over that. Birdman flies. So Bird stands for Burkitt's, Man stands for Mantle, and then Flies stands for follicular lymphoma. And In order to remember the type of translocation that is associated with every one of these forms of non-Hodgkin lymphoma, all you have to remember is that the number 14 is in all of these translocations. And then starting from bird going to flies, increase the number. So the smallest number that we had was 8, the next one was 11, and then we had 18. And now fit in number 14 in every one of them. 8, 14, 11, 14, and then 14, 18 are the forms of translocations that are associated with these forms of non-Hodgkin lymphoma. Now, in order to remember the type of genes that are involved, here I have another memory aid for you, which is called See My Bicycle. So c-Myc gene is associated with the Burkitt's lymphoma, while the BCL genes are associated with the mantle as well as the follicular lymphoma. Now let's go back to the table. So here we have the c-Myc, which is with the Burkitt's lymphoma, that was the translocation 814. BCL1 was with the mantle lymphoma, which is translocation 1114. And then finally BCL2 is with the follicular lymphoma, which is with the translocation 1418. And so you may recall that BCL2 was one of the anti-apoptotic proteins. So if the expression of BCL2 as an oncogene is increased, then it would lead to the development of the follicular lymphoma. Next oncogene is KRAS, which causes colon cancer, and I'm not going to go into too much details for now. I will review that later with you. RET gene will lead to the development of multiple endocrine neoplasia type 2. Again, the symptoms of MEN has been discussed in a separate video, so I'm not going to go into details here. ERB1 is associated with squamous cell carcinoma of the lungs, and then finally we have ERB2, which is also referred to as HER2-neu, which can lead to the development of breast, ovarian, and lung cancer. So the memory aid here is show hair breasts. And so you know that HER2 mutation is associated with the breast cancer. Alright, now that we are done with the oncogenes, we can move on to the tumor suppressor genes, which include the VHL, the first one. This gene is located on chromosome 3, and the way you can memorize it is that VHL has 3 letters. Now, the type of cancers that are associated with von Hippel-Lindau, which is an autosomal dominant disorder, includes the hemangioblastoma, clear-celled renal carcinoma, as well as the pheochromocytoma. The next tumor suppressor gene is the APC, which stands for adenomatous polyp and colorectal cancer. So adenomatous polyp and colorectal cancer, so APC. And this tumor suppressor gene is located on chromosome 5. So the way you can memorize it is that the word polyp has 5 letters. So APC is located on chromosome 5. And again, I will return to APC and discuss how this gene can lead to the development of colon cancer. The next tumor suppressor genes are WT1 and WT2, which stands for the Wilms tumor. And this type of mutation is the most common renal malignancy in children. Now, what you need to know is that mutations with the WT1 is associated with the Weger syndrome, where patients present with the Wilms tumor, aniridia, where the patients will lack the iris, genitourinary malformations, and then finally is associated with the mental retardation. So Weger syndrome is seen with the WT1 mutation. The next tumor suppressor gene is the retinoblastoma, which is located on chromosome 13. So the way I memorize it is that the number is actually embedded inside the RB itself. So here we have retinoblastoma, and then you can see that the number 13 are just embedded inside the RB itself. So retinoblastoma is located on chromosome 13, and it can lead to the development of retinoblastoma as well as osteosarcoma. P53, on the other hand, is another tumor suppressor gene that is located on chromosome 17, and it can lead to the development of multiple different cancers, which are referred to as Li-Fraumeni syndrome. Now, how to remember where BRCA1 and BRCA2 genes are located. So the way I memorize it is that BRCA1 and BRCA2 are going along with retinoblastoma and P53, but which one is with which? So BRCA2, the number 2, reminds me of retinoblastoma because that has only 2 letters. So BRCA2 is on the same chromosome as retinoblastoma, which is chromosome 13. and then BRCA1 goes with the P53, which is on chromosome 17. Now, how do you remember that P53 is on chromosome 17? Again, if you add up all the numbers, 17, 1 plus 7, or P53, 5 plus 3, all of them add up to number 8. So P53 is on chromosome 17, our retinoblastoma is on chromosome 13, BRCA2 is also on chromosome 13, and BRCA1 is on chromosome 17. Now, I keep on talking about BRCA, but what are their significance? Well, they stand for breast cancer, and it's easy to remember that BRCA2 is associated with breast cancer, as well as BRCA1, which is associated with breast cancer. But then both of these type of tumor suppressor genes can lead also to the development of ovarian cancer, as well as breast cancer in males. So the way you can memorize which one is more commonly associated with breast cancer in males, the memory aid is man to man. So BRCA2 is more commonly associated with the breast cancer in males compared to BRCA1. On the other hand, BRCA1 is associated with more cases of ovarian cancer compared to BRCA2 mutation. The next tumor suppressor gene is neurofibromas 1, which can lead to the neurofibromatosis. Then we have the DCC as well as the DPC tumor suppressor genes that are located on chromosome 18, and it's really easy to remember what type of cancers are associated with these tumor suppressor genes. All you have to know is to know what they stands for. So DCC stands for deleted colon cancer. So colon cancer is associated with DCC, while DPC stands for deleted pancreatic cancer. So DPC is associated with the pancreatic cancer. And then the final tumor suppressor gene is NF2, which can cause acoustic neuroma. And the way I memorize it is that since it has the number 2, it's located on chromosome 22. Now, you can recall that I told you I will come back to APC and KRAS genes. So normal colon can become at increased risk of developing cancer via the loss of APC, which was a tumor suppressor gene. And what happens by the loss of APC gene is that there would decrease intracellular adhesion as well as increased proliferation. After this point, KRAS mutations, which is an oncogene, can lead to increased expression of KRAS, as a consequence of which there would be unregulated growth that can lead to the development of adenoma. And then from here on, mutations that will cause inactivation of the P53 gene will increase the risk of tumorigenesis, which can lead to the development of carcinoma. So the way you can memorize the order of events that can lead from normal colon into the colon cancer is called AK53. So APC, K, 53. So AK53 is the order of events through which the normal colon can develop into the colon cancer. Alright, now that we are done with both the oncogenes as well as tumor suppressor genes, we can now go over the oncogenic viruses. So the human T-cell leukemia virus can lead to the adult T-cell leukemia or lymphoma. Epstein-Barr virus can lead to Burkitt's lymphoma as well as nasopharyngeal carcinoma. Human herpes virus 8 can lead to Kaposi sarcoma, and this condition is more seen in AIDS and immunocompromised patients. Hepatitis B can lead to the hepatocellular carcinoma, and then human papillomavirus can lead to the cervical cancer. It can cause nasopharyngeal carcinoma as well as the anal and penile cancer. So just notice that Epstein-Barr virus as well as HPV, both of these conditions that can lead to the development of the nasopharyngeal carcinoma. Alright, and now the last topic I would like to discuss with you is the tumor markers that are used for monitoring the progression or regression of a disorder. So these tumor markers, these are normal cellular components that are usually elevated in certain neoplastic tumors, and so we can use those as markers to see how's the progression of the disorder. If we are treating those patients with chemotherapy or radiation, how is the treatment efficiency by seeing those markers going down, and then also following up with the recurrence of a cancer. So the first marker is S100, which is used for monitoring melanoma, schwannomas, as well as neural tumors. And the memory aid I have for you is that S100 is used for monitoring progression of skin cancer as well as schwannomas. The next one is CA125, which is used for monitoring progression of ovarian cancer. So the way you can memorize it is that memorize this number 0125. So 0125, or ovarian cancer, is associated with the 125, CA125. Next we have CA199, which is seen in the pancreatic adenocarcinoma. So the way you can memorize it is that the number 9 and the letter P, these two are mirror images of each other. So therefore, CA19.9 is associated with the pancreatic cancer. So you can see how these two are mirror images of each other. Next, we have the human chorionic gonadotropin, which is increased with the hydatidiform moles, choriocarcinoma, as well as germ cell tumor. So HCG itself can stand for hydatidiform mole, choriocarcinoma, as well as germ cell tumor. So HCG. Next, we have the alpha-fetoprotein, which is elevated with the hepatocellular carcinoma, as well as non-seminomatous germ cell tumors. So the way you can memorize it is that the letter alpha-fetoprotein starts with F, and then if you continue in alphabetic order, it's FGH. So A, B, C, D, E, FGH, I, J, K, and so on. So F stands for fetoprotein or alpha-fetoprotein, G stands for germ cell tumors, and then H stands for hepatocellular carcinoma. The next type of marker is bombacin, which is used to monitor progression of neuroblastoma as well as lung cancer, and the memory aid I have for you is called bomb and blast the lungs. So bombacin is used for monitoring progression of neuroblastoma as well as the lung cancer. TRAP is used for hairy cell leukemia, so the memory aid here is TRAP, the hairy cells. Next we have the calcitonin, which is used for the monitoring progression of medullary thyroid carcinoma. ALP is elevated in Paget's disease of the bone, as well as conditions where there is metastasis to the bone or liver. And so for the Paget's disease, the memory aid that I have for you is that imagine pigeons that are flying on top of the Alps mountains. So Paget's is associated with the elevated alkaline phosphatase. Next we have the CEA, which is increased in colorectal and some other forms of cancers. So the way you can memorize it is colorectal. So CEA is elevated in colorectal cancer. PSA is easy to memorize. PSA stands for prostate specific antigen, so obviously it's elevated in the prostate cancer. We have beta-2 microglobin, which is elevated in multiple myeloma, which is a cancer of the plasma cells, or chronic lymphocytic leukemia. And then the last one is the HER2, which can lead to the breast cancer, and these patients are treated with the trastuzumab. So the memory aid that I have for you is trust the mob and show her breasts. So the HER mutation is associated with increased risk of breast cancer, and you will have to treat these patients with the trastuzumab. So trust the mob and show her breasts. Alright, now that we are done with the review of this topic, here is a quick quiz to check our knowledge and see how well we understood the topic that I just discussed. So let's go through this together and find out what's the gene that is causing neuroblastoma, lung cancer, B-cell lymphoma, and so on. So what was it that was causing neuroblastoma? And the answer was N-MYC. So N for neuroblastoma. And what is the tumor marker that we can use to track the progression of neuroblastoma? Do you recall that it was bomb and blast your lungs? So bombacin can be used to check the progression of both neuroblastoma and lung cancer. Now for the lung cancer, what gene mutations were associated with lung cancer? There were two. One for small cell lung carcinoma, and the other one was for squamous. So I'm going to give you a hint. The small one was associated with Mickey Mouse. Mickey Mouse is such a small mouse that it reminds, anytime I hear the name Mick, reminds me of small. So the answer was L-MYC. L for lung cancer, and then for the squamous cell lung carcinoma, I didn't provide you with any memory aids, but the answer was ERB1. And what is the tumor marker that we can use to track the progression of lung cancer? Again, bomb and blast your lungs. So bombacin can be used to track both the progression of neuroblastoma and lung cancer. Now for B-cell non-Hodgkin lymphoma, do you recall what type of mutations and then what kind of translocations are associated with these forms of lymphomas? So we had three types of lymphomas. Burkitt's, so here, bird, man, flies. So Burkitt's lymphoma, Mantle's lymphoma, and follicular lymphoma. So increasing number 8, 11, 18, and then number 14 was in every one of them. So these are the type of translocations that are associated with Burkitt's lymphoma, Mantle's lymphoma, and follicular cell lymphoma. Now, what type of gene mutations are associated with these forms of lymphoma? See my bicycle, BCL. So c-MYC was associated with Burkitt, BCL1 was associated with Mantle, and BCL2, which is an anti-apoptotic gene, associated with follicular lymphoma. Next we have the CML. So remember, I'm a tiny boy that likes Philadelphia caramel ice cream. So CML was associated with Philadelphia chromosome, where BCR gene has been translocated from chromosome 9 to chromosome 22, which had the ABL gene. And what was the medication that we would use for the treatment of the CML? And then the answer is imatinib. Imatinib. So I'm a tiny boy is used for treatment of caramel ice cream. Alright, now next we have the gastrointestinal tract. And do you remember what type of oncogene was associated with this type of tumor? So it's the KIT-CAT. So mutations in the c-KIT oncogene can cause gastrointestinal tract tumor. How about the colon cancer? What mutations can lead to the colon cancer, can make a normal colon turn into a cancerous colon? So here we had the colon, then we had colon at risk, then we had adenoma, and then after that, we had the colon carcinoma. And the memory aid that we had for this was AK53. So APC gene, which is located on chromosome. Can you tell me where APC is located? So remember the adenomatous polyp and colorectal cancer. Polyp has 5 letters, so this is located on chromosome 5. So AK, the next one is KRAS 53, and then the last one is P53 mutation. So where was P53 located? 5 plus 3 is 8, 1 plus 7 is also 8, so P53 was located on chromosome 17. And now let me ask you, which one is it that is located on chromosome 17? Is it BRCA1 or BRCA2? So retinoblastoma and BRCA2, these are located on chromosome 13. And then the BRCA1, the other one, is located on chromosome 17, where P53 is located. And then the final question, what mutation can lead to the osteosarcoma? So retinoblastoma gene can lead to both retinoblastoma and osteosarcoma. And then where retinoblastoma is located is on the 13th chromosome. All right, now moving on to the tumor markers. So what tumors, the progression of which tumors can be monitored by S100? So S can stand for schwannoma as well as the skin cancer. So what type of skin cancer? Melanoma. So melanoma and schwannoma can be tracked by the S100 tumor marker. How about CA125? So remember the memory aid 0125. So ovarian cancer is associated with CA125. How about CA199? So 9 is a mirror image of what alphabetic letter? P. So pancreatic cancer can be tracked by CA199. How about HCG? So every one of these letters meant something. So H stands for the hidradenitis mole, C for choriocarcinoma, and G for germ cell tumor. How about alpha fetoprotein? We had FGH. So alpha-fetoprotein is used for tracking the germ cell tumors. The non-seminomatous germ cell tumors is a type that can be tracked by alpha-fetoprotein. And H, do you recall what it stands for? So H stands for hepatocellular carcinoma. Next we have the bombacine. So it was bomb and blast the lungs. So neuroblastoma as well as the lung cancer can be tracked by the bombacine. And then what cancer can be tracked with the TRAP marker? So remember, it was TRAP, the hairy cells. So hairy cell leukemia can be tracked by the TRAP protein. For calcitonin, I didn't provide you with any memory aid, but that's used to track the medullary carcinoma of the thyroid. Then we have the ALP, so pigeons on ALP, so Paget's disease, as well as metastasis to the bones or liver are associated with elevated levels of alkaline phosphatase. How about CEA? Do you recall what kind of tumor can be tracked by CEA? And so the answer is colorectal. So CEA can be used for tracking the colorectal as well as some other kind of tumors. PSA is prostate-specific antigen. It's used for monitoring the progression of prostate disease as well as benign prostatic hyperplasia. Beta-2 microglobulin is used for tracking the progression of multiple myeloma as well as the CLL. And then finally we have the HER2. So what kind of cancer is associated with HER2 mutation? So remember, trust the mob and show her breasts. So hair mutations are associated with breast cancer, and the type of treatment that you used is trastuzumab. And so that concludes our discussion of this topic.